Well, this concludes our chapter on gender dysphoria, paraphilic disorder, and sexual dysfunction. I hope it's been helpful. I hope you're moving along well. We're getting near the end, so until the next video, bye for now. Hi, and welcome back to Abnormal Psychology. In this chapter, we're going to be looking at gender dysphoria, paraphilic disorder, and sexual dysfunction. Now, we're going to do this, I think I might be doing it in 3. I'm not sure just yet, so I'm sorry. No. Okay, we'll just leave that part out and get right into after that intro part. Go into attitudes towards sexual activity are incredibly diverse. What is normal is clearly influenced by socio-cultural factors. Sexual behavior may be labeled as abnormal if it deviates from the norms of whatever one society happens to be where you live. Now, it may also be labeled as abnormal if it's self-defeating, harms others, causes personal distress, or interferes with one's ability to function normally. Let's consider Sally and Dave. Sally and Dave decided to seek therapy after only 8 months of marriage. Both are extremely dissatisfied with their sex life. Dave complained that Sally never initiates sex and found excuses to avoid it and appeared to fake orgasm during intercourse. Sally, she complained that Dave's lovemaking was often brief, perfunctory, and without much affection. During the therapy sessions, it really became clear that Sally had never had a strong interest in sex and seldom became aroused during intercourse. Now, although Dave had never had difficulty in maintaining an erection, sex with Sally had become progressively distressing, and he often had difficulty getting in, hard enough for intercourse. Now, this case of Sally and Dave, it's really illustrating that psychological and physiological complexities associated with one of 3 groups of disorders that we're going to review in this chapter. Sexual dysfunction, this involves problems in the normal sexual response cycle. The other 2 disorders, gender dysphoria, it's distress resulting from an incongruence between a person's gender identity, who you see yourself as being, and the assigned gender that you were born with. And then the 3rd grouping is the paraphilic disorders. This is the problematic sexual interest and fantasies and behaviors. And we're going to begin with a review about what constitutes normal sexual behavior, and then we'll conclude this chapter with a review of sexual dysfunctions. Now, for this chapter, we're going to look at descriptions of the disorder, the theoretical perspectives, and the treatments for each group, one group at a time. Now, this follows the chapter. Okay, here's where I'm going to get into it again. However, it makes for a longer video, but I'm going to put it all into one rather than 3 separate ones. So let's get started. Gender dysphoria. Now, in gender dysphoria, an individual experiences significant personal distress or impaired functioning as a result of a discrepancy between his or her anatomic sex, the biology, and the gender identity, which is, of course, influenced by, strongly influenced by sociocultural factors. And there's a disconnect in this. Gender identity is the type of gender identity that a person has psychological sense of being of one gender or another, just one gender though at a time, and processing the sexual organs of another. So you have the belief we'll use me as an example. Let's say that I have I am genetically a male, but if I really identify in my mind as to who do I see in the mirror and how do I think about myself, and I think of myself more as a female, then that disconnect is what is in fact a part of gender identity disorder. Now, not all people with gender identity have gender dysphoria disorder, as many are not distressed about their identity and have access to support that they need. Gender dysphoria pertains to people who find that their anatomic gender to be a source of persistent and intense distress. People with the disorder may seek to change their sex organs to resemble those of the opposite gender, and many do undergo gender reassignment, surgery that is, to accomplish those purposes. Now, it is important to understand that sex and gender are not interchangeable. Sex relates to our biology. Gender is created by the society. It's a socially constructed perspective. Now, part of the issue with gender is how we tend to treat it in terms of polar opposites, men and women. However, gender is more on a continuum. Men at one end and women at the other, but there is many variables in between. In our North American culture, we generally recognize that there are two genders. However, in other cultures, the social construct has sometimes got more. There are cultures with 3 genders and even others with 5. It really reminds us of how to connect gender to culture and society is really important. And that's, gender is what it is to be masculine and what it is to be feminine. Sex is about biologically, which are we? So let's look at some of the theoretical perspectives regarding this issue of gender dysphoria. The psychodynamic theorists point to extremely close mother-son relationships. Remember, they're all about the history, old school time, looking back in childhood. So that would make sense from them. Parents with empty relationships and fathers who were absent or detached, or girls with weak and or ineffective mothers and strong masculine fathers may develop stronger little men identities and behavior. Well, the learning theorists, they have a similar focus where the socialization patterns have a big effect, and they point to father's absence, in the case of boys, to the unavailability of a strong male role model. However, socialization is not the sole responsibility feature in the development of gender. To better understand, in your textbook, there's a bit of a story there, a short bit of blurb about Bruce. He's from Winnipeg. And it's a good example where there is way more to this gender dysphoria, if you will, than just socialization or parenting style of the development of gender dysphoria. It needs to be considered in terms of some of the biological predispositions, considering that gendered brain and the role of sex hormones. And that's a much more complex issue than just strictly you're a man and you're a woman. Prenatal hormone imbalances may also be involved. Some of the research suggests that perhaps the brain is masculinized or feminized by hormones during certain stages of prenatal development. So that's a curious element, and it'll be something to see what happens as they do more research in those areas. So if we're looking at the treatment for gender dysphoria, well, the recommended treatment of gender dysphoria includes hormone therapy, real life experience. That means that before you can go through any surgery, you must live as the other gender for at least 1 year. And then you can, should you desire, to go through a sex reassignment surgery. And there is some use for some people using a psychotherapy to rid some of the historic history from their own background that they find is really interfering. Not every person with gender dysphoria seeks gender reassignment. Some of the more known people who have had gender reassignment are Cher Bono's daughter, Chastity Bono, daughter of Sonny and Cher Bono. You'll see a picture I have there of Chaz Bono on the right, and that was in 2011. And Bono has a gender identity disorder and has undergone hormone and surgical procedures to transition from female to male. Now the other picture there is Jenna Telkakova, a Miss Universe 2012 contestant. She finished in the top 12 at a 62. And of course, you would be familiar with Caitlyn Bruce Jenner. Now, of course, these individuals are maybe more famous. There are many not so famous who also pursue gender reassignment. All right, let's look into that second grouping, the paraphilic disorders. And we're going to review the types of paraphilic disorders that there are, and we're not going to cover them all. There are a lot. Paraphilic disorders are types of sexual disorders in which a person experiences recurrent sexual urges and sexual arousal fantasies involving non-human objects, such as clothing, inappropriate or non-consenting partners, such as children, or situations producing humiliation or pain to oneself or to one's partner. The person has either acted on such urges or is strongly distressed that they have them in the first place. So what kinds of paraphilic disorders can we look at? And we'll look at the ones that are in the textbook. Exhibitionistic disorder, fetishistic disorder, transvestic disorder, voyeuristic disorder, frauderistic disorder, pedophilic disorder, sexual masochism disorder, hypoapophilia, sexual sadism disorder, and sadomasochism. I know it's a long list, and we're just going to briefly highlight just what they are, but there are way more fetishes than just these. Some people are diagnosed with paraphilias, can function sexually without the paraphilic object, and some cannot. Most people with paraphilic disorders are men. Women may have been overlooked in the research, but there doesn't appear to be as many examples. Now I'm going to review each of these types, and we're just going to do a quick overview of them to give you some perspective. Exhibitionism. This is the recurrent and powerful urge to expose one's genitals to unsuspecting strangers. There is not any interest typically in any contact with their victims. Most just participate in the act, and it's the response that they get that is of interest. Either it's a surprise response, a shock, or sexual arousal of the victim. All of those possibilities are what this is about for this disorder. Fetishistic disorder. This is the recurrent and powerful sexual urges and fantasies involving inanimate objects. Clothing, shoes, a body part like feet, or a situation involving sight, smell, or feel. The transvestic disorder. Now, you're going to have to pay attention here on this one because it's misleading. Recurrent and powerful urges to cross-dress for purposes of sexual arousal. Now, this is not the same. This is why I need you to be careful here. It's not the same as gender dysphoria, as men are typically heterosexual and do not consider themselves a woman. Voyeuristic disorder. Now, these again are urges and fantasies involving the acts of watching unsuspecting people while they're getting naked, or are already naked, or are engaged in sexual activity. Now, the person either acts on these urges or is, again, very distressed about having them even in the first place. The frauderistic disorder, the urges and fantasies involving rubbing against or touching a non-consenting person. Again, the person either acts on these or is just very distressed about even having these urges or fantasies in the first place. Now, this next one is certainly one it's a taboo. It's a sociological term to describe the sexually charged that these are not things you do. Pedophilic disorder. It's a recurrent and powerful urges and fantasies involving sexual activities with prepubescent children. Now, this is particularly damaging disorder and can have long-lasting consequences to the survivors of sexual abuse. Now, although some paraphilias are essentially harmless, such as fetishism, others, such as pedophilia and sexual sadism, often harm non-consenting victims. It's important to note, children cannot consent. Now, there's a pathway, if you will, and they call it a development of persistent sexual offending against children. It sees there's two basic pathways: antisociality, and the second being sexual attraction to prepubescent children, and that's the pedophiliac. The presence of both indicates a very high likelihood that the person will offend against children. We'll move into this sexual masochism disorder. These urges and fantasies are involving receiving humiliation or pain. Either they're acted on, or the person is again very distressed about even having these thoughts and fantasies. This can include the dangerous form of masochism called hypoxophilia. That's the autoerotic asphyxiation. It's arousal through the restriction and deprivation of oxygen. Of course, it has some serious side effects if it goes wrong, and it goes wrong more frequently than I would imagine most of you might think. The sexual sadism disorder, these urges are involving inflicting humiliation or pain on a sexual partner, either acted on or is very distressed about these urges and fantasies. Sadomasochism, the sexual activities between partners involving gaining gratification by inflicting and receiving pain or humiliation. Now, there are other paraphilic disorders, and many varied ones. We won't get into them all. But let's consider the theoretical perspectives to maybe understand the source, where they come from. And the psychodynamic theorists see many paraphilic disorders as defense against leftover castration anxiety from the Oedipal period. Now, remember, Freud's work here were very speculative and not researched and evidence-based. So these forms of psychodynamic therapies are speculative at best. There's no real direct evidence for it, but it is, Freud is still a researcher that has some say in the area of abnormal in psychology. Now, the learning theorists, they explain paraphilic disorder in terms of conditioning and observational learning. Some objects or activities become inadvertently associated with sexual arousal. Paraphilic disorders may involve multiple biological, psychological, and sociocultural factors. Now, as far as any treatment of paraphilic disorders is concerned, therapists of various theoretical persuasions have attempted to treat clients with paraphilic disorders. Psychoanalysis, for example, they are attempting to bring childhood sexual conflicts, typically the Oedipal nature, into awareness so they can resolve it in the light of the individual's adult personality. Behavior therapists have used aversive conditioning, for example, using electric shock to induce a negative emotional reaction to paraphilic stimuli or fantasies. Now, within the biological, we can look at the selective serotonin reuptake inhibitors, or the SSRI. They're used in treating exhibitionism, voyeurism, and fetishism. Researchers think that there may be a relationship between fetishes and OCD. Efforts to treat paraphilias are compromised by the fact that most people with these disorders don't really want to change, so why would I go and get it fixed? We'll jump into a topic that doesn't really fit, but it relates, and it's called sexual assault. Sexual assault is a violent crime, not a sexual disorder, and it's an important distinction. The desires to dominate women or express hatred towards them may be more prominent motives for rape than sexual desire. The sociocultural perspectives suggest that cultural attitudes such as the stereotype of male aggressiveness and social dominance underlie propensity to rape. Rape survivors often suffer a range of immediate and long-term effects. So as far as sexual assault, we're not going to go into covering this topic as it's not a psychological disorder and it's not supported in the DSM-5. This is not meant to diminish the seriousness of sexual assault. We will jump into sexual dysfunction. Sexual dysfunctions involve problems with sexual interest, arousal, or response and can be grouped into the following categories. The first, disorders involving problems with sexual interest and arousal. The second group, disorders involving problems with orgasmic response. And then the third group, involving pain during sexual intercourse or penetration. And this is, of course, more specific to women. Now, for a diagnosis to be made, a clinician needs to determine that the problem is not related to the use of drugs or medication or other medical condition, severe relationship distress, or serious stressors, and is causing personal distress. And it has to last at least 6 months. So as I've mentioned in a few of the other chapters, make sure you read the DSM-5's criteria for a diagnosis to get an idea, one, what things need to be included and how long do things need to last to be counted as a disorder. Disorders of sexual interest or arousal. Now, there are two separate disorders related to men and women. Male hypoactive sexual desire disorder and female sexual interest arousal disorder. And as you may have thought, what is normal level of desire? What's normal? Well, much investigation needs to go into a diagnosis as there are many variables to consider. Male erectile disorder is related to the attaining or maintaining of an erection. Now, this does not include the occasional difficulty that one might have, but for the persistent or reoccurring episodes. Orgasm disorder includes 3 types of disorders. Female orgasmic disorder, and that's basically the inability for a woman to achieve an orgasm. For men, premature ejaculation or delayed ejaculation, which is either the absence of an orgasm or a persistent, reoccurrent delay of reaching orgasm. And then the third is the genital pelvic pain penetration disorder. And it's diagnosed by a persistent and reoccurring pain experienced during vaginal intercourse or penetration attempts with 4 primary symptoms. Difficulty with vaginal penetration during intercourse. Secondly, the pentopelvic pain during vaginal intercourse and penetration attempts. 3, fear of pain in anticipation of vaginal penetration can be a part of this. And then 4 is the tension of the pelvic floor muscles during attempted vaginal penetration. Now, some forms of genital pelvic pain penetration disorder involve vaginismus. So to get a handle on some of our sexual dysfunction things through theoretical perspectives, sexual dysfunctions, like most psychological disorders, reflect a complex interplay of biology, psychology, and other factors. Sexual dysfunction can stem from biological factors such as disease or the effect of alcohol or other drugs. Diabetes is one of the most common organic causes for erectile dysfunctions. Testosterone has a huge role in sexual interest and functioning in both men and women. Biological issues are a major cause of sexual dysfunction. Now, learning theory, they look at the role of conditioned anxiety. Anxiety being linked to sexual activity, thus learning that sex or sexual situations are anxiety producing. They also look at the sexual fulfillment through our trial and error with sexual partners, and messages that we have learned from these experiences. For the cognitive theorist, irrational attitudes and beliefs are considered here for the sexual dysfunctions. Faulty thinking, catastrophizing, globalizing, meaning that not this specific relationship, but all relationships turn out this way. Fear of failure or performance anxiety. The sociocultural perspective includes such factors as sexually restrictive cultural learning. Sex used to be thought of as a male activity. For women, it was more of a duty. Then this would not expose women to self-awareness sexually. So what we learn from tradition, what our roles of men and women are according to our culture. Culture will often dictate how are we supposed to behave and perform sexually. Now we get this from media, movies, we get this from porn and access to porn. It all can have an effect on how our lives through our sexual lives are affected, good and bad. So if we move into the treatment of sexual dysfunction, one of the big areas that had a big push early on was sex therapy, and it focused on directly modifying problematic sexual behavior by enhancing self-efficacy expectations, teaching sexual competency, and improving sexual communication, and also reducing the performance anxiety. Now, this work in the area of sex therapy was pioneered by a couple of doctors, Masters and Johnson, back in the 1960s. Now, disorders of sexual interest or arousal, the therapist will try to use sexual fantasy and self-stimulation to rekindle the sexual appetite. In some cases, testosterone replacement therapy is useful where the hormones is deficient. Disorders of orgasm, well, the relationship between anxiety and sex and poor exposure to positive self-awareness about one's own sexuality. Here, the therapist assists with the reconnecting sufferers with a more positive view of sex and one's own sexuality. In these instances, masturbation is often encouraged to learn about what feels good, what is desirable without the need of a partner, and to look after their needs or to have those issues be a part of this discovery. Now, the genital-pelvic pain penetration disorder, vaginism is not a physical defect. Rather, it is a psychological state effect where uncomfortable intercourse is the result. And treatment involves a cognitive behavioral techniques using relaxation techniques and the use of dilators to improve the sexual experience.